Honorable Chairperson on the dais, distinguished delegates, it's a real privilege to stand here today in front of you. And I really take this opportunity to thank the organizers for giving me this opportunity. Thank you very much. And I really congratulate you for organizing this such a wonderful conference. Thank you very much for the kind introduction. Today morning when we are discussing about the finer aspects of cancer care, why are we discussing pediatric palliative care or the pain management? What is the context here? Today in the field of cancer, I think the childhood cancer is the success story. In the West, children are not really dying of cancer anymore. They say that more than 80% of children are cured of cancer. So what's happening in our own country? It seems as we are still struggling with the mortality of children with communicable diseases like diarrhea, measles, tuberculosis, there's a slow rise in childhood cancer in India. And in most of the hospitals, they say that children are still dying, a very low survival rate because of various reasons, and our children are dying. And while we are still struggling with setting up palliative care or pain programs in different parts of the country, a program very dedicated to children palliative care is very few in the country. We can really count on our fingers how many programs are there for children palliative care or children pain program. I work in a cancer hospital, which is a regional cancer center for the state of Telangana and Andhra Pradesh. And we have a very comprehensive pediatric oncology program where we see a lot of children with, mostly children with leukemia. We did a small survey for children who were going to the medical oncology department, just an outpatient based survey done by our medical students. We just asked them one question. Did you experience any pain in the last 1 week of your life, last 1 week? And what we found that the children who were going to the medical oncology department, not in palliative care, 99 out of 100 children, they said, yes, we did experience pain. And we asked them, what kind of pain did you experience? They gave a common list. If you see, very surprisingly, or not so surprising, the most common cause of pain was procedural related pain. The children expressed that the procedure they had to undergo for various reasons, what is the most painful experience which they experienced, and then came the cancer pain. More than 70% of them, they said, the experience was moderate to severe degree pain. I don't know how much you understand by this implication. Moderate to severe means if you try to score from 0 to 10, they said it is more than 6, 7 to 10, such severe pain they were having during the last 1 week of their life. This is not very different from many of the studies which were published in the western part of the world. There also they found that procedural pain was more common, but the cancer pain was also highly prevalent in children with cancer. Like any other hospital, in my hospital also, the most common cancer is leukemia, and then lymphoma, and then other solid tumors. Most children, when they undergo cancer treatment, it's not like adults. It's very invasive, like all people who are working in childhood cancer, they know more about it. It's very invasive. Every treatment is preceded by some investigation, which is again blood count, bone marrow, and during the treatment, again it's very invasive, intrathecal, intravenous treatment, less of radiation. So the whole experience becomes very painful for children. The various procedures they undergo for the treatment for cancer. The children who are referred to our Department of Pain and Palliative Care, are mostly children who are really still undergoing curative treatment, like children with leukemia, or children undergoing cancer treatment but with palliative intent, like neuroblastomas or solid tumors, or sometimes directly they are referred to palliative care for end of life care. So we see children in all stages of their life for cancer pain management. If you see a child at the top being still investigated for cancer, she's not yet diagnosed, but she has some mass and she's being investigated. Here is a child with severe mucositis because the child was undergoing treatment for cancer and chemotherapy, and of course a child with very end of life care. And we also see children in all age group, 0 to 18, a very small babies, very newborn babies with hepatoblastoma, or 18-year-old girl with osteosarcoma. So what is the impact of pain? Why are we discussing pain here? Children very often present in various states of disability when we see them. Either they are very irritable, restless, crying, or simply withdrawn. They just refuse to talk, and they just become withdrawn, and the parents say, at home they were very playful, off late they stop playing, and they just withdrawn. Or they failure to thrive. They stop eating, they stop sleeping, or posturally, they become very, assume this posture, they refuse to get down from others' lap. Also, it is very well known, several textbooks are written about the consequences of pain. If the child survives from treatment from cancer, they grow to become an adult, but they experience high level of pain, disability even in the adulthood. They grow to develop a lot of chronic pain syndromes, a lot of this neck pain, back pain. Often they say it's often because of some childhood pain experience and post-traumatic stress disorder. I remember I was speaking to a group of cancer survivors in Delhi. They were college-going children who had finished their leukemia treatment, and they were survivors. And when we were speaking about these experiences, I remember one student got up and said, I still get nightmares as if I'm pinned down by people and people poking something on my back. I remember, and I get nightmares about it, the whole experience of getting treatment, cancer treatment. A lot of textbooks are written about how cancer is so common, children pain, cancer correlation, and also disability. But still, the pain for children is very poorly recognized and treated. So some of the consensus, and what are some recent advances the people have made about cancer pain management is very simple. I'm not going to detail, but just highlighting based on what we have in India, the medications which we have in India. The most important part of a very successful pain management in children is a proper assessment. Like any other pain management, it starts with good assessment for children. And they say that self-report is the gold standard. Just like an adult, the child has to be asked for pain. Do you have pain? And children, they tell you if they have pain. They say that as a baby as small as 2-year-old can tell you whether they have pain or not. Maybe they will show you how much, this much, or this much, they'll show you, but they can report pain. A child 4 to 5, they can standardize. Of course, 6 to 7, they can start rating properly, 0 to 10, like that. But they can report pain. It's a matter of asking them. Several scales are available. People also draw on the body chart, children, and they show their pain. It's a matter of, again, doing a good assessment. Some principles which we must follow if you're talking about managing pain in children, chronic pain. I'm not talking about acute pain, chronic pain. Please remember, plan whatever you are with medication which can be given orally, because that's the very least invasive and less painful. By the clock and by the ladder. By the clock is very relevant in children, especially because you know that when you give any opioid medication, it takes several hours to build up that therapeutic blood level, and to build up each time you need higher dose of opioid. So if you don't do it by the clock, there's a cycles of under medication and pain, and then alternating with periods of over medication and drug toxicity. It's a simple approach which we follow in adult. I'm sure all of us are very familiar with 3-step analgesic ladder for pain management, which was introduced by the World Health Organization. Same principle which we follow in children. Step 1, step 2, step 3. Step 1, for mild pain, we use non-opioids. Step 2, moderate degree pain, we use weak opioids. Step 3, severe degree pain, we use strong opioids. It's depending upon the severity of pain, not the stage of the disease. If I see a child in lot of severe pain, when the child is still undergoing investigation, I may start on step 3 medication because the child is having severe degree pain. It has nothing to do with the stage of the illness. In non-opioids, we talk about mostly NSAIDs and paracetamol. The recommended NSAIDs, which are recommended by the World Health Organizations, are only mostly these analgesics. Acetaminophen, paracetamol is the most wonderful, safe analgesic for use in children. And other than that, we can use ibuprofen, naproxen. Aspirin is not used anymore so much. But definitely, very well studied drugs are ibuprofen and naproxen, which we can use very safely in children. Many other NSAIDs are available, but these are very well studied NSAIDs. Opioids in children. The moment we talk about opioids, it brings a lot of fear, even in adults, but more so in children. And children, it makes it a little more complicated because we feel there aren't enough studies. We don't understand the pharmacokinetics or pharmacodynamics. But there are enough literature available to talk about use of opioids and its safety and its efficacy. The weak opioids which are available in India are codeine, tramadol, buprenorphine. I think all of us are very familiar with the use of codeine. Children, pain, opioid means often we think about codeine, and all of us are very comfortable using codeine. So what is the recommendation about codeine? Codeine is a weak opioid. It's a prodrug of morphine, which means that if you take codeine, it is converted in the body into morphine, and then it gives its action. So many times people are saying, why are we giving codeine then? Why can't we straight away give morphine? Why do we want the codeine to go into the body, get metabolized, and then work as morphine? And it's 1/10 the potency of morphine. It's again, if you're giving codeine, please give it 4 hourly, because the duration of action of codeine is only 4 hours. Codeine can be very constipating. And more people are not recommending use of codeine. In fact, the recent recommendation by World Health Organization, they have withdrawn codeine from the WHO 3-step ladder. They say don't use codeine because also, as I said, it is metabolized in the body to morphine. There's a lot of individual and inter-ethnic variability. Some are slow metabolized, some are fast metabolizers. So they say better not use it. Tramadol, yes, all of us are very familiar with the use of tramadol. There are studies available and they say it's quite safe to use tramadol. We can use tramadol if we don't have morphine, yes, as a step to analgesic. I know that many pharmaceutical companies, they talk to us about tapentadol, another form of tramadol. Not much studies available, so I recommend that let's use only tramadol for children. Buprenorphine, I just mentioned here because a lot of, I'm sure medical representatives to come to you talking about buprenorphine patches. They say, put it on 7 days, you don't have to worry about anything. But there are very few studies done in children, so we are not very sure about its use in children. Step 3, the strong opioid. Morphine remains a drug of choice. This remains a gold standard. Again, morphine, just like adult, please use it 4 hourly. There is no SOS dosage. Remember, we spoke about that, no PRN dosage. It has to be given 4 hourly. Enough dosage for breakthrough pain. Breakthrough means, suppose in between they get more pain, ask them, encourage them to take breakthrough pain. There is no upper limit. Oh, I've used only 20 milligram, 4 hourly, what next? Go to 30 milligram. Increase the dose till the permissible level, till the patient either develops side effect or patient gets pain relief. But clear instructions to the parents as to how to use morphine. Very clear instruction has to be given. Fentanyl is a wonderful drug, very quickly metabolized, very short acting, rapid onset, and very safe in children with kidney failure. We use a lot of fentanyl in a lot of this acute pain situations, like procedural pain, post-operative pain, sedation in children, pain of malignancy, and of course in pediatric palliative care, end-of-life care sedation, we use fentanyl. Very short acting, quick onset, and rapidly they come out of it. So it's very safe. But if you are talking about using transdermal patch, I'm sure many of us, the oncologists, are very used to using transdermal patch of fentanyl in adults. But if you are using children, better to consult with some pediatric pain specialist. Side effects of opioids, like in adults, constipation remains the most common side effect. Don't underestimate constipation in children. If you are using opioids in children, please use laxatives. Like an adult, and stimulant laxative is recommended. And we have other side effects just like other opioids. We do also have toxic effects if it is exceeding the therapeutic level. The child will become drowsy, confused. Respiratory failure is a very late concern. It's not really concern because before that they will become drowsy. But we have to be careful. So that's the reason we titrate the morphine, regulate it. There are a lot of myths when we use morphine in adult, more so in children, like don't give morphine. If you give it now itself, it won't work towards the end of life, which is not true. We can always go up on the dose of morphine. Nothing like it will not work towards end. We can use higher dose of morphine. Morphine hastens death. which is not true. When the child eats well, pain-free, he eats well, he sleeps well, he plays better. In fact, we have seen they live longer than child who is not being treated properly for pain. Morphine causing addiction is again a fear among public, lay people, and among doctors, which is again not true. There are several literature available talking about oral morphine. If used judiciously, it does not cause addiction. And we have an Indian study which came in Lancet. Again, they looked at what is the problem of addiction. They found it is not significant. Remember, all pain cannot be treated with morphine. Lot of neuropathic pain syndrome. A child having, for example, having sarcoma here and a neuropathic pain syndrome in the arm, they may need other adjuvant medications like tricyclic antidepressants, anticonvulsants. So we have to consider adjuvant medications. More and more, if you go to any good pain clinic in the West, they talk about integrative pain approach. Integrative, it's not just one is pain management and then you talk about psychosocial support or supportive care. No, it should all go together. That's why they talk about integrative pain management, where we should work in a multidisciplinary team and involve the children with a lot of other integrative approach. Involve the child and the family in the care. Tell them, talk to them about what we are going to do. Tell them what it's all about and involve them in the care, decision making. Talk about a lot of other physical therapies, touch, massage, warmth, distraction techniques, and of course a lot of cognitive behavioral techniques that are all very useful in bringing the overall level of pain. And this is very relevant in pediatric pain management. There's some pictures here, how they've shown this picture. If you see a child, mother is holding the child, and this gesture itself allays the anxiety of the child and brings down the pain. If you see, there are a lot of studies about babies, and you give them sucrose, that pacifiers with sucrose, when they suckle that, they don't experience so much pain when you're doing the procedures. Bubble therapy, distraction therapy. When you're doing the procedure, let the baby blow bubble, or some distraction techniques which they are doing with reading books. So to conclude, pain in children is very common. This, in addition to when they're facing with life-threatening illnesses, adds a lot of emotional and physical burden in children and their families. Two-step analgesic ladder approach is very effective for chronic pain management in children with cancer. And oral morphine is a drug of choice given in proper dosage and with the proper PRN dosage. It's very effective for effective pain management in children. Thank you.